Welcome. This is a joint grand rounds with our colleagues from obstetrics who attend high-risk rounds. So I'm sure you're all familiar with the Zoom format, but I will just reiterate it. If you could keep your microphone muted when you're not speaking. And I'll be moderating the question period after rounds. So you can submit your questions starting around 8:45 through the chat icon, and I will read them aloud to the speaker at the end of the presentation. And if you want to voice your approval or applause, please go to the reactions icon. So as is tradition with grand rounds, we do a traditional territories acknowledgement. So I would like to acknowledge that the University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, as well as on the heartland or the homeland of the Métis Nation. We respect the treaties that were made on these territories, and we acknowledge the harms and mistakes of the past. We dedicate ourselves to moving in partnership with Indigenous communities in a spirit of reconciliation and collaboration. On behalf of the Department of Pediatrics, I would also like to acknowledge the lives lost, the 215 Indigenous children who were found in a grave site in Kamloops residential school. The Department of Pediatrics acknowledges the incalculable harms caused by the Indian residential school system and the ongoing systemic racism in our healthcare system. And all of us here today remain committed to reconciliation and collaboration with our Indigenous communities. So it's my pleasure to introduce our speakers today. Doctors Catherine Kearns, Christina Raimondi, Dr. Megan Azad, and Dr. Lauren Kelly, as well as Sarah Turner, who is a PhD candidate in Dr. Azad's lab. By way of introduction, Sarah Turner is one of 5 UofM Vanier Canada graduate student scholars. So we welcome them all. And we're going to hear today about collaborations across specialties to improve breastfeeding rates and outcomes. So the virtual floor is yours. I will stop screen sharing now. And I hope I did that, right? Yes, okay.
Yeah, now I gotta figure out again how to do mine. Oh, there it is.
Hello, Catherine.
Hi. Hello. Hello, Azad. Okay. So present. Okay, you guys can. Okay, can you? Never mind. Okay, so yeah, so like Dr. Burke said, clinicians across specialties and research, so collaborating and working together. So we're very excited to present at both Pediatric Grand Rounds and Obs-Gyne Grand Rounds, high-risk rounds. Just a quick note, also Dr. Nathan Nickel will be presenting with us as well. So today our objectives are to describe the updated 10 steps to successful breastfeeding and how to implement them in your practice, both in hospital as well as outside and in clinic. And also to review a family-centered collaborative approach, so among the specialties. So that's spanning the prenatal, postpartum, and infant feeding timeframe to overcome barriers and try to improve our breastfeeding rates. Describe a collaborative approach between clinicians and academic researchers in this field. There's a lot of exciting stuff happening in research in Manitoba right now for breastfeeding. So that's very exciting, some of the collaborations that are happening and that we hope to continue to happen. And then describing an updated approach to medications in breastfeeding. And at the end, we'll talk about maybe how you guys can get involved if you're interested. So I'm going to hand it over to Dr. Nathan Nickel. Just quickly, he's an MPH PhD, MILC co-director, associate professor in community health sciences at the University of Manitoba. Nathan?
Thanks so much, Catherine. So we wanted to start off by giving a really high-level overview of the 10 steps to successful breastfeeding. By way of background, in the late 80s, early 90s, there was a declaration that came out with the WHO and UNICEF called the Innocente Declaration, which really focused on removing barriers to families achieving their own breastfeeding intentions that were in place and very prevalent in the hospital systems around the world. So they comprise a set of key clinical practices and policies that, when implemented, have the capacity to support families to achieve their breastfeeding intentions. Next slide. So the first step of the 10 steps is having a set of policies in place at the hospital level that are really aimed at supporting families to achieve their breastfeeding intentions. And then it's out of those policies that the practices unfold in order to ensure that barriers are removed. The second step involves training of staff to be able to provide breastfeeding support. And depending on the type of care an individual provides within the hospital setting, will determine the extent and the nature of that training. But the training involves improving knowledge around breastfeeding practices, knowledge around the biology of breastfeeding, but also clinical care practices and how to implement clinical care practices to support breastfeeding. The third step is around supporting pregnant women to provide them with information around breastfeeding, how to manage breastfeeding once they give birth, and starting to work with them around understanding what their own breastfeeding intentions are. And this is intended to occur during the prenatal period. The fourth step focuses on those practices that take place immediately after the birth of a child. So looking to support uninterrupted, immediate skin-to-skin contact between the birthing parent and the infant. And this is, there's been a lot of evidence to show that this helps support sugars in the baby. It helps to support body temperature regulation in the baby, but it also supports a baby to initiate breastfeeding during those first hour, which is the other component of step 4, which is supporting moms and birthing parents and babies to be able to initiate breastfeeding shortly after birth. Next slide. Step 5 is around providing birthing parents with the skills to continue breastfeeding. So things like how to express human milk, initiation of latch, positioning. All of these are skills that work with a mom during those first few hours of the baby's life to help ensure that she has the skills and efficacy to achieve her own breastfeeding intentions. Step 6 focuses in on supplementation. So really wanting to work with families to ensure that if they intend to be discharged from hospital exclusively breastfeeding, that they're supported to do that. So some research that's come out of hospitals has shown that by providing supplementation during those first day or 2 days of life before breastfeeding is fully established, can really inhibit the flow and the cycle for breastfeeding and get in the way of families being able to achieve their own intentions. Obviously, if it's medically indicated, then supplementation is to occur. This is really for that supplementation that is not medically indicated. Step 7 is around rooming in and is just to support moms and babes to stay together during the birth hospital stay. And this has been shown not only to improve breastfeeding success amongst families that intend to breastfeed, but also has several other health benefits associated with it for both the mom and for the baby. Step 8 focuses in on helping a mom to identify and respond to hunger and satiety cues, being able to identify when their baby is hungry due to signals that the baby gives, but also while the baby is being fed, to be able to identify when the baby is full, so as to avoid overfeeding. It also deals with paced feeding in the event that a birthing parent or a family decides to bottle feed an infant. The discussions around paced bottle feeding would also be included within Step 8. Step 9 is talking about providing bottles and pacifiers and nipples, artificial nipples to babies. And this is really, again, focusing in on those babies and families that have intended to breastfeed, because there's been some research to suggest that providing artificial nipples gets in the way of a mom and baby learning how to effectively latch early on. This is really focused in on those first couple of days while breastfeeding behaviors are being established. And then finally, Step 10 is focused in on making sure that families are connected with community supports for breastfeeding, so that once they're discharged, they're able to access the resources and supports that they require in order to sustain their breastfeeding behaviors during the first several months of life. And there's been a whole host of studies that have looked at these steps in combination, but also individually, that demonstrate each of these has a unique contribution to sustained breastfeeding, exclusive breastfeeding, breastfeeding duration, and they've also been linked with other health outcomes for both the mom and the babe. Next step. Another key component of the Baby Friendly Hospital Initiative, which includes the 10 steps, but also includes what's known as the World Health Organization Code of Marketing for breast milk substitutes, is around how human milk substitute products, products such as infant formula, can be advertised to families. And so this really deals with some of the more coercive marketing practices that have been in place, that have been executed by formula companies. So there's been a body of literature that's documented that after exposure to human milk substitute advertising, formula advertising, family self-efficacy to achieve their own breastfeeding intentions is compromised. And so those marketing practices really undermine families' ability to achieve their own breastfeeding intentions. And so as a result, part of the code of marketing is to ensure that formula advertising is not present in the healthcare system, really in an effort to ensure that families are able to achieve their own intentions. And in fact, we've seen that this has taken place in the current context of the COVID pandemic, where families exposed to formula marketing have increased concern and fear around breastfeeding, and has undermined self-efficacy for breastfeeding. Okay, next slide now. There's been a lot of implementation science studies looking at how to implement the 10 steps of successful breastfeeding. There's evidence to show that the 10 steps and the practices comprising the 10 steps really support breastfeeding, really support families' health, and are evidence-based. But the question is, how do we get these practices into play in the healthcare system? Some studies have likened it to climbing a mountain. It's incredibly challenging. Some work that's been coming out of the US that I've been involved with has been testing out the IHI model for quality improvement, which really brings together a collaborative approach, an all teach, all learn, building cohorts of hospitals that can learn from each other on what works and what hasn't worked to implement the 10 steps. And those quality improvement initiatives are really based on what's called a PDSA cycle, or a plan, do, study, act cycle, where small tests of change are tried out with each of the 10 steps. A couple years ago, I partnered up with Breastfeeding Committee of Canada to work with them on a collaborative that includes hospitals from across Canada to implement the 10 steps to successful breastfeeding with the ultimate goal of increasing the number of hospitals in Canada that are designated baby friendly, and the number, as a result, the number of families giving birth in hospitals that are designated baby friendly. This collaborative has been underway for the past year and a half, and we've been trying out different PDSA cycles, different strategies to support hospitals across the country to implement the 10 steps. Here in Manitoba, we have 2 participating hospitals. And we also have Brandon community that's participating. And what we've seen is, over the past 18 months, an improvement in the practices described in the 10 steps. We've also seen a statistically significant increase in the families that are being discharged from hospital, exclusive breastfeeding, as well as achieving their own breastfeeding intentions. So we're currently doing some preliminary data analyses to write these projects, these papers up. So we're not at a point yet to share those results, but there's some really exciting learnings happening from hospitals across the country. And with that, I will pass it on to the next speaker.
We'd like to introduce you to the woman who does meet her breastfeeding goals more often in this country. She is white, she's well educated, she's got money in her bank account, she's cisgendered, married, and had an uncomplicated pregnancy and uninterventionalized birth. We should all be disturbed about this, because breastfeeding is a human right and clearly a social justice issue. Health Canada tells us that over 90% of women initiate breastfeeding in hospital, and by 6 months, only about 30% are exclusively breastfeeding. So what's happening when they leave the hospital? Well, women tell us in surveys that they perceive to not have enough milk, that they get into technical difficulties with breastfeeding, or that there's some maternal infant illness that gets in the way. What they're not saying is that they're choosing to stop. So what we're hearing from this is that women are choosing to breastfeed in hospital, and then something happens when they leave, and their choice becomes not actionable and not accessible. Next slide. This chart was adapted from a great review on the barriers to exclusive breastfeeding published last year. And it simplifies things into 3 categories: individual factors, environmental factors, and society, cultural factors. And you can see that the hospital environment is only one line in this whole chart. There's so many things that are involved. In our clinical experience in our outpatient breastfeeding clinic, we see that the more layers of barriers a family has from multiple boxes, the further away from exclusive breastfeeding they have. So why, you might even be asking yourself, why is exclusive breastfeeding important? And it is because it is the easiest thing to do for families, rather than washing bottles, purchasing something, questioning how much the baby needs. It is associated with the best health outcomes, and it's associated with the longest duration of breastfeeding. So it should absolutely be supported. And as clinicians, as physicians, right, our power is in the patient relationship. And we're the best person to understand how these layers affect our patients. And we're the best people to identify which women are at risk during their pregnancy, at delivery, which infants are at risk for breastfeeding challenges, and who better to educate, inform, diagnose, provide expectant management to that family's specific needs and give that family validation for why things are going right or wrong and how to get them back on the right path. Next slide. This is a great study from BC Women's Hospital. They surveyed women as they left about their experiences, and most women had a great experience. 85% said nurses were great with helping breastfeeding, but still, the majority, 2/3 of women had concerns going home that were related to infant feeding, feeling overwhelmed, and just not knowing how to settle their baby. Because it's hard, right? It's hard even if everything goes right. And they noted that certain groups needed additional support, such as families who've never done this before, women who had abdominal surgery, and women from certain ethnic groups. Next slide. The American College of Obstetrics and Gynecology published a great committee opinion in February of 2021 on barriers to breastfeeding, supporting initiation and continuation of breastfeeding. And these were their key messages. They support informed decision-making free from coercion and bias, a multidisciplinary approach from everyone, practitioners, community, family, employers, hospital, to overcome all these obstacles, educate and advocate for policy changes like baby-friendly that facilitate breastfeeding, discuss how the barriers intersect for that family at play, and really emphasized the need for education for breastfeeding management for clinicians and all medical staff around childbirth. Next slide. What we're talking about is really advancing equity and inclusion. If we treated all families the same, we're missing families to be able to access breastfeeding. So if we bolster families up who have added barriers, and those bolsters are the hospital environment, the care that they get from their physician, inpatient, outpatient, the community supports, the government policies, then more people can access breastfeeding and the health benefits of breastfeeding. Next slide. From our very own Dr. Azad and Alan Becker is there too, and I apologize if there's other Manitobans here that I don't recognize. This study showed that supporting exclusive breastfeeding in hospital predicts longer duration of breastfeeding, but also had implications for health equity. So they found that even if we just have that moment with them in hospital and we can support them exclusive breastfeeding in hospital, you're reducing the risk of them stopping breastfeeding later by 21%. And that benefit was highest among women with no post-secondary education. So disadvantaged women and their children stand to benefit the most from policies supporting exclusive breastfeeding in hospital. And this has significant influence on reducing health equities across the lifespan. Next slide. The World Alliance on Breastfeeding Action is an organization that promotes the protection of breastfeeding around the world. They have Breastfeeding Month, which is August, and Breastfeeding Week. Internationally, it's the first week of August, and in Canada, it's the first week in October. This year, the theme is a shared responsibility, and it talks about how the warm chain of supports, or mom and baby, are at the center of the chain, and it follows mom and baby from pregnancy to the child's second birthday, and all the players involved, the village in supporting that family to achieve their breastfeeding goals, from physician to policymaker to academics to advocates. Everyone has a shared responsibility. Next slide. They even made these little cards you can download or order from their website, specifically saying what an obstetrician or a pediatrician physician can do to support breastfeeding. And much of these guides are really just providing evidence-based medicine, informed decision-making, and up-to-date logistical real-world support around breastfeeding, just like you do with anything else in medicine. There's not one about family medicine, unfortunately. I didn't find one, but there's a pediatrician, obstetrician, community. There's a father one. There's a few of them. Next slide. I'll let Dr. Kearns take over.
Dr. Kearns, you're on mute. I'm not sure if you're speaking.
Okay, sorry, I was, thank you. Let me do that again. My screen, it's not letting me have Zoom end this.
That looks great, and we hear you now. Oh, not hearing you.
Pregnancy and birth are normal, healthy life events, but that you do need that village of support, including the physicians. So it's not convincing people, pushing them to feed. I'm going to comment on this chest feed that we have here. That's just more inclusive language. For example, a trans man who still has breasts, who has a baby and wants to chest feed because does not want to consider them female breasts. Shaming, we're not shaming or judging people who make different choices, especially and we shouldn't be making people suffer through challenges. Pain is a big one that people say, well, your nipples just have to get used to it. So sure, pain is common in the beginning, but it's not normal. So if there is pain, something needs to be fixed. The latch probably needs to be adjusted somehow to be more comfortable. And again, cheerleading and providing not providing evidence-based care is not something we should do because, again, in all areas of medicine, we focus on evidence-based care, not just cheerleading on the sidelines. So busy slide, but just highlight some things. The early parent-child attachment is critical. That's that skin to skin early on, which is guidelines across our hospitals and in all care environments. Again, research evidence, holistic approach, collaboration among the different providers. So things that are going on in pregnancy that put, or before pregnancy even, but that put mom and family at risk of breastfeeding issues, and things that happen during labor, are those things being communicated to the people who are taking care of the baby and the family postpartum, so that those can be integrated. And you know, we should all have the whole picture, no matter when we have contact with that family, so that we can provide appropriate care and support. Again, the culturally appropriate care is important. We live in a multicultural society. Indigenous peoples have distinct needs during pregnancy and birth and after, and recognizing that not everybody is the same, and you need to, and again, as Dr. Raimondi mentioned, we are in a perfect position to individualize our care. We know these families, and that teaching them, part of our role as physicians is teaching patients and families, teaching them and giving them information that actually breastfeeding is, there are myriad of health benefits for mom and baby. Making sure we're including them in the decision making and respecting reproductive rights. Again, determining the unique needs of the family, continuity of care. That's one of the real drivers behind this talk, is that we need to be collaborating across this time. It makes no sense for one provider and then one second provider and nobody's communicating, because that's not helpful for the breastfeeding success. And then minimizing barriers. So a quick mention on kangaroo mother care. There was a study that came out of the Public Health of Canada, and showing the benefits of kangaroo mother care. That's holding the baby skin to skin, carrying the baby sort of like a kangaroo does, obviously. Pretty self-explanatory. And recognizing that actually you get increased rates of breastfeeding. So here's a variety of studies showing that. And this study actually was done for low birth weight infants, and they found actually that doing immediate skin to skin before a baby is stabilized in the 1 kilogram to 1,500 grams, like 1 to 1.5 kilogram size of babies actually benefited more and did better if they were directly skin to skin versus stabilized first and then skin to skin. So interesting stuff, worth looking into if you care for babies of those preterm and low birth weight babies. So considerations for real world, right? Like, we all work in the real world. Are there logistical barriers in your practice, in hospital, in clinic? Is there equity in your practice? Have you taken time to seriously look at that? How do we identify families at risk? How do we communicate that to the family? Managing expectations, and also the whole healthcare team. Is there something we could do differently in documentation, for example, at the hospital, so that that information is passed over? Prenatal education on breastfeeding, are we talking about it? Usually those visits are super short. Are we, and also with COVID, we've decreased the amount of them. Is there enough time to talk about it? Are we assessing families at social and medical risk? And also, you know, if you're a pediatrician and you're seeing children who are child visits and mom's pregnant, and there were issues breastfeeding that child, are we having discussions about breastfeeding the next one? Anticipatory in terms of when mom is having this baby, is there any resources that she can access to try to get on top of that before the baby's born? And then your hospital, right? What is the progress on these 10 steps? What is the communication like? How does the hospital bridge the inpatient and outpatient care for mom and baby? Again, you know, going out and then mom is seeing OB or baby is seeing peds, or they're both seeing family medicine. And how do we bridge all that information so that everybody has the whole picture to be able to support them in an individualized way? How does the number of visits, right? Are we seeing patients enough to affect their breastfeeding success? Are we supporting breastfeeding during these visits, postpartum visit, child visits? And then is there any way for us to receive feedback from patients and use this to improve care? That's quality improvement is a big thing in medicine right now. So is that something that we could be doing more of in this area? So I will pass it over to Dr. Megan Azad and Sarah Turner.
Thank you, Dr. Kearns. Excited to be here to tell everyone a little bit about the Manitoba Interdisciplinary Lactation Center. So MILC is co-directed by myself and by Dr. Nathan Nichol, who you heard from earlier today already. This is a new center launched in the last year or so, a little bit slow due to pandemic, but definitely getting off the ground. And everyone you're hearing speak this morning is part of our MILC Club, which I'll tell you a bit about in a moment. So Nathan and I envisioned MILC as an interdisciplinary center to study breastfeeding, other infant feeding practices, but also human milk, and to link those into the data that we have in Manitoba at an administrative level. And so we come from, as you can see, two different backgrounds, and I think really complement each other. And then we've broadened that even further with the other now members of MILC. So I come from a background in basic science, cell biology, human milk science, and epidemiology. And Nathan comes from a background in public health as well as biostatistics. And so MILC is founded on really three pillars. The first being infant feeding and lactation databases. So prior to starting MILC, Nathan had launched the Manitoba Infant Feeding Database, which is a really unique resource collecting feeding data on infants in Manitoba. So you may know that at the Manitoba Centre for Health Policy, we have something called the Manitoba Population Research Data Repository, which is a fantastic resource for research, and it comprises administrative databases from the health system, but also from the social services system. So this includes physician billing claims, hospital abstracts, prescription records, as well as records on access to social services in Manitoba and even education outcomes. These are all available for research in a de-identified way, and they're all linked together, meaning that we can study how health services are affected by social services, the determinants of different diseases in the population, the tracking of those diseases over time. Everyone in Manitoba with a health information number is in this database. And so it's a really fantastic resource for doing policy research. But one thing that was missing out of this database was information about infant feeding. And so in Nathan's project, he had started to develop a feeding database where moms would be asked about their feeding practices when they're attending their well baby visits, and that this information would then be captured and integrated into that database. And so you can imagine this would give us a lot of ability to study things like, I saw in the chat, someone mentioned the breastfeeding clinic at HSC was unfortunately closed a couple of years ago. So with a provincial level feeding database, we would be able to look at what were the breastfeeding rates before that closure and then after. We also could link feeding data to things like maternal and infant health outcomes. So this was something Nathan had started before MILC, but was running out of funding. So with MILC, we've been able to continue that. The Human Milk Biorepository is the portion of the project that I direct and I'm really excited about. So here we're starting to collect milk samples from moms who, when they're filling out that feeding survey, will also be asked, would you like to donate some breast milk for research? And then we're creating this biorepository as a resource. So when we analyze the human milk for different components, whether they're nutrients or other bioactives, we keep that in a biorepository and get permission from the moms to link it to their administrative data. And so in the future, this will again be a really unique resource where we can understand how different components in human milk are related again to maternal health. And that would be the entire lifespan of health data from that mother if she was born in Manitoba, and also to the health outcomes of the infants as they grow up. So this is unique in the world, I have to emphasize. There are a couple of research human milk biorepositories, but none of them have this available ability to link into administrative databases. Next slide. So the MILC Club, as I mentioned, is really where this presentation was born out of. So we meet monthly on Zoom for now, and we have researchers and trainees from various disciplines as part of the MILC Club, as well as clinicians. So Dr. Kearns and Dr. Raimondi, primary among them. And then we also have other healthcare partners. So individuals from the WRHA, the Health Sciences Center, and the Manitoba Breastfeeding Network that regularly attend these meetings. And so it's truly interdisciplinary and collaborative. You can see a photo here. Last year, we held a Café Scientifique, and we do other things like develop studies together. It's really important for us to have that clinical connection in order to recruit research participants, and of course, sharing our evidence with the public and providers to increase the impact of our work. Next slide. And anyone is welcome to join us, so you can reach out through our website. Okay, next slide. So I know we're getting tight on time, so I'll go quickly through these. We have lots of interdisciplinary collaborations, both looking at research studies, education initiatives, and also writing projects together. Here's an article from the conversation that Sarah, who you'll hear from next, co-led with one of the postdocs in our group. We did have our first MILC publication earlier this year, which was exciting. This was a commentary. There was a paper that had a title that bothered some of us, talking about inflammatory breast milk in obese women. And so we collectively wrote a commentary about the messaging and important methodological considerations that are necessary when researching breastfeeding and obesity. You can see there a little clip from the article where we said that as this collective group of scientists and population health researchers and lactation professionals, we were concerned about the messaging in that article. Next slide. This is another article that you can check out if you're interested, but it was born out of a workshop that Nathan and I co-directed a couple of years ago that really speaks to the importance of interdisciplinary perspectives in this field. Next slide. So I'm going to pass it over to Sarah Turner to talk about one of our initiatives on teaching children about breastfeeding at school.
Thanks so much, Megan, and good morning, everybody. So this is a really exciting initiative that we have going that is really an outreach tool. So as we've heard today, that breastfeeding rates in Canada and across the world, especially in high-income countries, just really aren't where we would like them to be. And so there's lots of clinical interventions that can be done, but also looking more broadly from a public health perspective, how can we educate not only moms, but the public in general, and even looking early into life and into school-age children about the importance of breastfeeding, about how interesting it is, and just to normalize the practice in society. And so we are working on this project to implement some school-based breastfeeding resources to reduce social stigma and improve social support for breastfeeding, and to just help support more mothers in society. Next slide. So this, and you can also click one more time. There we go. So this project has two phases. Our current phase, our first phase, phase 1, is completed, and our current phase, phase 2, is actually just on hold due to the pandemic, because it's a lot to try to implement some school-based resources at the moment when school is not even happening in person. So in our phase 1, which we've already completed, we did several things. We just first started out with a scan of the curriculum in Manitoba. Was anyone teaching about breastfeeding? Was this important? Was this included in any curriculums? And we found out that it's not officially included, but there is a program called Roots of Empathy, which is available in some schools, which helps school children learn about baby development. We then identified toolkits from other parts of Canada, the US, and actually across the world of different institutions, different provinces, different school boards that have actually developed breastfeeding-based curriculum that could be implemented from kindergarten all the way to high school. And then we did an online survey as well as focus groups with some educators and healthcare providers in schools to ask them about their aptitude towards teaching breastfeeding education in schools. What did they think about it? Did they think it was necessary, and why? Our next phase, which is currently on hold, will include co-developing resources with some of our educators that will actually be willing and able to implement these in the classroom, and then to evaluate them to see, does teaching about this in school actually improve or change children, young adults' attitudes towards breastfeeding as they grow up. Next slide. So I'm just showing you a couple of results from this online survey that we've done. We included 39 educators, 66 healthcare providers. 12 of these educators were already actually talking about breastfeeding in their classrooms just on their own initiative. And when we asked them about if they supported teaching breastfeeding in schools, the vast majority said that yes, it should be included. Now, these were self-selected participants, so there's a bit of bias here, but there is quite a bit of support for this. And the reasons that they cited were to encourage normalizing breastfeeding, to prepare students to be future parents, and then also to provide accurate information about the benefits, challenges, and choices associated with breastfeeding. So again, this is not a coercive initiative, but this is really information providing, where we want people to be informed about all of the benefits of breastfeeding, all of the things that the baby can get from that, as well as the mom, so that they can make their own decision and what's best for them with the information provided. And with that, I'm going to pass it on over to Dr. Lauren Kelly to talk about medications in breast milk.
Great, thanks, Sarah, and good morning, everyone. So one of the projects that we have been working on with MILC is around drugs and how they pass into breast milk and the effects that may have on the infant. There's lots of reasons why moms may need to take medications for either chronic or acute conditions in the postpartum period. And there's not really a lot of good evidence to support healthcare providers and families making decisions around medication use. So lots of the research is retrospective, and I won't talk too much about all of the challenges there, but it means that they don't generally collect milk, they don't look at drug levels in milk, and they don't necessarily follow forward the infants to see if there's any impact on drug exposure during lactation. And this creates a lot of barriers to informed decision making. Next slide. So there's lots of different factors. So I'm a pharmacologist in the Department of Pharmacology and Pediatrics, and there's lots of different factors that contribute to how much of a drug gets into breast milk and how much an infant is actually exposed to. So I won't talk too much about what those are, but essentially most drugs do transfer to breast milk in very small amounts. Next slide. So this makes a lot of decisions for moms. So we've been doing a lot of work with some community partners and some parents with lived experience around decision making. So if you're taking a new medication, you have to think, what happens if I don't breastfeed? There are a lot of benefits to breastfeeding, and parents have to make difficult decisions around if they are not going to be breastfeeding because of a medication. What happens to their baby if they continue to take the medication? And again, there's not often a lot of good quality research to support what the long-term effects might look like. And then, of course, what happens to themselves? So what happens if they don't take their medication? So it makes a lot of decisions around, are they going to formula feed? Are they going to change the timing of their medication administration? Are they going to change drugs? And how are they going to care for their baby while they're using those medications? Next slide. So just a couple of sources of information. There's a few really great sources of information. There's not a lot of literature out there, but they are collated in a few easy access places. So Mother to Baby, Medications in Mother's Milk, which is Thomas Hale's guide, Infant Risk, and LactMed. These are all free. Lots of them have applications that you can use on your phone as well. Some not so good sources of information. These are generally the product monographs, package inserts, stuff that comes from the companies. And I'm sure you're all used to seeing that warning that says, this drug has never been tested in pregnancy and breastfeeding, so we don't recommend that you use it. And that can create an overcautious approach where some women may be losing out on benefiting from either a therapeutic or may be advised not to breastfeed when there really is no indication for that. Next slide. So some of the research that we have going on in this area, and the great part about MILC is when we link the population health database with actual biorepository and milk samples, we can look at drug levels. So we can look at how much drug is passing into breast milk and actually correlate that, look at things like variability, factors that contribute to variability, but also look at following these infants forward using population health data to see if there are any adverse impacts. So we have a project that's funded by the Radiant Innovation Fund, looking at commonly used medications during breastfeeding, and this is using the child study cohort data, and developing collection methods and analysis protocols. So this is where we've been doing a lot of community outreach and working with parents who actually have lived experience making these decisions, and some even donating breast milk for research. We have a graduate student, Dr. Christine Leong, and I working on a systematic review and developing and the validation of some assays in collaboration with the College of Pharmacy. And then we also have some work looking at decisional needs assessments, both from a parent perspective, but also from the perspective of healthcare providers. So it was a very quick overview of some of the research we have going on here, and I think I'm going to pass it back to Dr. Kearns to talk about the next bit.
Okay, sorry, I thought I was muted again, but
no, we can hear you.
Okay. So really quick, just a couple more minutes. She quickly mentioned the medications in breast milk study. This is, you can see that, it started with looking at methods for everything around choosing medications during breastfeeding. Currently in the survey point where we create surveys for individuals and healthcare providers in terms of their feelings and thoughts and preferences and all that around medication, all to get to the point of creating a decision aid for healthcare providers and potentially for families. Now, this is the steering committee, and I just wanted to highlight this just to show you guys how
Unfortunately, it looks like
information, Academy of Breastfeeding.
We're good. Go ahead, sorry.
Academy of Breastfeeding Medicine has some protocols for all kinds of situation and decision-making around breastfeeding. It's a international group of physicians doing breastfeeding medicine. And IABLE for learning stuff. And then she already mentioned LactMed. And yeah, resources. So the associations have some. The CPS. Anyway, you can look at that. I will say that the American College of Pediatrics and American College of Obs and Gynae seem to be ahead of our Canadian associations in terms of stuff out there in terms of supporting. It is on the agenda for the next executive meeting of the SOGC to talk about having some sort of guideline for providers for supporting breastfeeding. So we're working on that. And then and then the public health piece, we talked about that a bit earlier, but if you want to look into it more, and then the WABA with the warm connection for supporting. So just so we can get to questions, becoming more involved. So join MILC Club. We actually have family medicine, pediatrics, breastfeeding. We do need representation from obstetrics if anyone's interested. And then Dr. Laura Hayek is a doctor in Montreal who's trying to recruit doctors from across the country to create a breastfeeding interest group in the Canadian Pediatric Society to try to help our associations and societies improve our breastfeeding support documents and information. And also get involved in clinical research on breastfeeding. And then should we create a working group? I'd like to open that for discussion to help address barriers between departments and communication and collaboration. So if you'd like to email me for any of these things, I can direct you to the proper people. Also, I know that the MILC website link was put in the chat if anybody wants to look there, but I will open it up for questions.
Thank you to all. That was a fantastic presentation, and I think it really highlights the importance of teamwork and scientific and medical collaborations for problem solving. So really excellent. I'll start with some of the questions that have been coming throughout your presentation. So the first was sort of the mental health and postpartum depression impacts on breastfeeding. Can you comment on that?
Absolutely. Dr. Raimondi here. So we know that postpartum depression and breastfeeding have a bidirectional relationship. Breastfeeding exclusively actually is protective against postpartum depression, but women who have a history of depression or who are struggling with breastfeeding might have an exacerbation of their depressive symptoms, which highlights the need for support. These women who struggle may still have a very strong intention and determination to breastfeed. And so enabling them from their choice is important. So providing information and guidance, group support, treating their depression with medication is all the more important in that population.
The next question is, what's been the local experience with rates of breastfeeding during the pandemic here in Winnipeg?
That's a great question. I'm not sure if anyone here can answer that. I'm not sure that we have that information. I mean, in terms of what I can say from the Winnipeg Breastfeeding Center, we actually had it really exploded in terms of patients coming to us last summer with all of the supports stopping in the community and public health having to all be redirected to COVID, that a lot of those programs and things have come back sort of online, some of them. There seems to have been a rise in social media support groups because we know peer support is important. And then, yeah, but I don't know about actual numbers. Can anybody else comment on that?
Yeah, a brief comment on that. So we'd love to have that data. Unfortunately, during the pandemic, the feeding database kind of stalled just because it does rely on the different practices to be helping us with collecting those data. And of course, everyone has been overwhelmed with pandemic-related activities. So in Manitoba, we don't have hard data on that, but certainly there's been research around the world around breastfeeding rates during the pandemic. And actually Sarah, who you heard from earlier on our team, and some others have been doing some research around this and looking at, in some cases, it's a benefit. Moms are working from home, so they're able to be with their babies longer. But as Catherine just mentioned, the support system, so the support groups and the home visits are lacking. I'll let Sarah comment on that. I see her video on.
Sure, yeah, thanks, Megan. Yeah, we've seen an interesting kind of paradox between moms who, it seems to be moms who already have been having an easier time. So Dr. Raimondi mentioned at the beginning, the profile of the mom who does have quite a bit of privilege in the beginning. The pandemic seems to, while it is challenging for all, not had the drastic impacts of making things much more challenging compared to the mom who is having breastfeeding challenges. So some moms have cited, I liked not being able to, or not having so many people come over and visit. I just had this time to nest and bond with my baby. I didn't have so many other things to be going off to. But on the other hand, some moms who said, I couldn't get the care I needed. We had a tongue tie. I couldn't get it figured out. So there really have been kind of two sides to this coin of how the pandemic has affected experiences of breastfeeding. But again, the numbers, the actual rates still seem to be a bit fuzzy. We don't quite have that information yet.
Thank you. So next question, occupational therapists obtain community referrals for infants with feeding and swallowing difficulties. Often they are bottle feeding before they get referred. Are we able to refer to you if the family is wanting to return to breastfeeding, or do we need to ask the primary physician to make the referral?
So we do require a referral to see patients at the Winnipeg Breastfeeding Center. We can facilitate that though. And if official consult for Manitoba Health has to be a physician, a midwife, or a nurse practitioner. But if it's another healthcare provider, we do have a form that we can send to the healthcare provider. And if people don't have a family doctor, for example, someone delivered the baby, right? Someone was there for the birth. So there's always a healthcare provider we can reach out to. And we have a form that they just have to tick off yes and sign and send it back, and they can actually bill for that. So we tend to have a lot of success with that. So that's something we can do to help. We do have a website, and on the website there is an email and phone number that has our staff person that you can reach out to them to try to figure out how we can facilitate that for you guys. Great, thank you. I, among many in the audience, have lamented the loss of the breastfeeding clinic. So question specific to Children's Hospital, where we will admit infants with breastfeeding jaundice, dehydration. Mothers are struggling with breastfeeding. Are there lactation services available to these mothers who are rooming in with infants? We struggled with this, and many of the nurses on the wards have assisted, but I think that's an area where there's a real gap within our center. Yeah, I completely agree. It's the provincial children's hospital, and there's no in-house support for that. This is one of the silver linings of COVID, is that we have virtual care now, and we can provide virtual care. And so we can actually do virtual visits and we've done them on the postpartum ward with moms. We've done them in children's as well. So we've done virtual visit the mom is in the hospital room with her baby and doing a visit that way. So at this point, that is one way for access to happen. And then in the future, depending on if virtual care continues, it's actually allowed us to do care in the north as well, which has been great, just sidebar. But if we continue to have access to virtual care, we can continue to do that. But if that goes away, we'll have to figure out another way. Mm-hmm. Well, that's actually very helpful to know because that assists with the transportation, obviously, for the provider coming to hospital. I have a question about pasteurization. It was mentioned in passing for donor breast milk. Does that process inhibit some of the natural components of breast milk? I know in pasteurization, I think afterward, you need to add some of those vital components to regular milk. So how does that affect pooled donor milk?
Yeah, excellent question. So pasteurization does affect some of the active components of breast milk, in particular cells. So breast milk contains maternal immune cells as well as live microbes, some of which can be pathogens, which is the reason for pasteurization, but some can be actually commensal, healthy, beneficial microbes. Also some of the other bioactive components, enzymes, and so on. Many of the components, though, do withstand pasteurization. So milk oligosaccharides are one example. These are prebiotics that support the gut microbiome. They're unaffected. So there's a mix, but that's one of the reasons that we think there are differences between feeding mom's own milk versus pasteurized donor milk. And there's lots of ongoing research around better ways to process donor milk to preserve that bioactivity. And then you touched on fortification. So kind of regardless of whether it's mother's own milk that is not pasteurized or pasteurized donor milk, fortification is required for very low birth weight preterm infants in order to meet their nutritional needs. And we actually did a randomized trial to look at and compare to 2 different types of fortifiers. So that's definitely an active area of research.
Mm-hmm. Yeah, and lots of comments in the chat. Maybe you can just summarize those about passive immunity, either through immunization or infection with respect to SARS-CoV-2.
Yes, so of course, a really active area of research in the last year has been related to COVID and breastfeeding. Initially, there was a really big push to understand whether the virus was transmitted through breast milk. Many of you may know HIV is transmitted through breast milk, and there was sort of some issues around getting that evidence quickly enough during that outbreak. So we wanted to make sure that wasn't repeated in the COVID times. So an international collaborative effort showed that the virus is not transmitted in breast milk. And then the next question was, what about passive immunity? So it has been shown that COVID antibodies are transmitted in breast milk, whether that's after infection or after vaccination. There's still ongoing research to understand what impact that has on the infant, but the assumption is that those antibodies would be protective in the infant at a time when the baby can't be vaccinated directly. So really important to continue breastfeeding during the pandemic.
And I also saw, Megan, you can probably confirm this, that they found both IgA and IgG?
Correct. And the profile is different so when a mom has been infected and recovered, her antibody response is primarily IgA. And then as opposed to in vaccination, the antibodies seem to be primarily IgG. So interesting sort of immunology questions to be explored there.
Yeah, that is not expected. Interesting. So thank you, Ken. I'm just looking if there are any other.
Well, I have a question and a comment.
Okay, go ahead.
So we know that any baby who gets any breast milk does better than babies that are exclusively bottle fed. And I think one of our harm reduction strategies should be to look at women who are planning to exclusively bottle feed and try and encourage them to immunize the baby with breast milk or colostrum. It's a simple harm reduction strategy. It saves the judgment and the science and stuff, and it is a marginalized group that would benefit from breast milk. And I would also encourage the breastfeeding clinic to remove the consultation barrier, because that can be 2 days, 3 days, a week to get a consultation back. It's a barrier to marginalized women who don't have access to primary care. And I think that consultation requirement should be removed if we can reach out to those women. So those are my comments from an old guy.
I'm going to say I think that's a higher policy, a government initiative, a billing initiative, if I'm not mistaken, not necessarily a clinic administrative issue. It's how it has to do with compensation, I believe.
Yeah.
But compensation isn't the main issue here. Isn't compensation. It's improving breastfeeding. And 24, 48 hours, it can be too late. I think most of the women can get a consultation, but those who can't shouldn't be denied access to skilled breastfeeding support. I just don't think that's acceptable.
We 100% agree with you, but as a fee-for-service clinic, we still have to pay the bills. And so at the end of the day, we're advocating with Doctors Manitoba to for some Manitoba health changes for sure.
Yeah, I think you're preaching to the converted here. It's just a matter of how we, address that so that we do improve access for all. But that is the systemic barrier for sure. Okay, well, thank you
Tricia?
all.
Tricia from Brochet.
Go ahead.
I think this is a problem. It's Elska from Brochet. And I'm part of MILC. I've been to a couple of meetings, and I think it's a fabulous committee/working group. One of my challenges as a pediatrician, and I think a lot of people face this, is we've been asked to write prescriptions for formula because then it's covered by NIHB and or Jordan's principle. I have a lot of difficulty doing this. I know it's not best practice to support breastfeeding, but I feel very torn because families are asking me and they are getting coverage some way. And I think we need to address this as an advocacy work. Do you have any comments, team?
I think it comes down to informed decision making. Like, really, we shouldn't be approaching it like in a paternalistic way and saying, you shouldn't have this. Really, I think backing up a little bit and having that conversation with the family about what the benefits of breast milk is, why it's important, what their values are, what they want to do, how they want to feed their baby is kind of the root of understanding why they're asking for the formula, and it's kind of starting back with the basics.
100% agree. That's a fabulous answer. It does seem to go, though, against the breastfeeding code that formula shouldn't be. Well, anyway, you're right. And I guess we just have to do our pre-work so that parents are not asking for formula prescriptions.
Right. It's like that cultural and societal barrier, right? That is kind of predominant in that environment. So
Norway House, I asked them what they're doing about it, and their band, whatever, is actually they're providing breastfeeding parents with the same money that formula-fed parents would get in order not to disincentivize breastfeeding. So I thought that was very clever, but I don't think that's universal.
No, I agree, Elska. I think it goes against our grain to prescribe something that we know is harmful to a child. So I have a lot of trouble, and so far I've managed to dodge it. So.
Yeah, so I think that these are very worthwhile questions, and there are a number of questions regarding referrals, and I think these can be taken offline with the experts here in the audience. Don't hesitate to reach out. And I think, in terms of advocacy, your monthly meeting group is the place to start. And I'm certain the MPS and Department of Pediatrics would support such advocacy activities. So in the interest of time, we will convene for today. Thank you again. Fantastic session, very interactive, a lot of interest in this area. And we will see you again in September when Grand Rounds resumes. Bye, everyone.